Welcome to Quality, where we're exploring quality in emergency care. This is your host, Arjun Venkatesh, and this episode is part of our new series focused on improving quality for venous thromboembolism as part of the Emergency Quality Network Initiative. Today, I'm joined by Dr. John Sather, who's an emergency physician at Yale and co-leads the EQUAL Venous Thromboembolism Initiative with me. And our special guest is Bill Malcolm, who's Senior Director of Data Science and Quality at ACEP, and someone that we've worked together with for years developing the ACEP quality registry, a variety of quality measures, but comes to us today with probably one of the most unique and special perspectives because he's literally done it all. He has been in government, he has learned data science and informatics, he knows emergency medicine and data registries, but so relevant to our work that we're doing in this, he's also had a PE. And so, Bill, it has been a joy working with you over the past couple of years, but I have found that working with you and you sort of having this diagnosis has in many ways given me a lot of purpose for what we do. And I was hoping you could sort of, share your story of that PE and sort of how that sort of intersected with your work at ACEP.
Well, thank you for the invitation, Dr. Venkatesh. Working on the VTE program has been very enlightening, as well as the other measures and things that we do here with the college. For me personally, back in January 2021, I did catch the COVID virus. At that time, I didn't have many symptoms. It seemed like the flu. And shortly thereafter, in one of my legs, I found that there was swelling and other indications of something being wrong. Went to a physician who sent me for an ultrasound. Upon completion of that ultrasound of my leg, I was not permitted to leave the ultrasound facility on my own. They insisted that I immediately proceed to a hospital. The interesting thing there was that I clearly understood what was going on at that point. I had heard that VTE was a symptom and side effect of the COVID virus. And I was whisked off to the hospital where they did confirm the diagnosis as well as some extensive pulmonary embolisms. And I spent the next 4 days in the hospital under treatment. I'm glad to say all went well. After a thrombectomy and various treatments, I was able to leave the hospital with no major ill effects. So I was very happy for that. It was an interesting experience for me. Both because I had done all this work on VTE and doing the measure development, and I found myself living it as they went through and they ran the tests that we use as qualifying for the measure and things of that nature. I knew what they were doing and why they were doing it, but it is different to actually experience it. That was a new thing for me, but it was also very insightful and helped me to understand what the patients are going through for the measures that we do have, as well as what the physicians were dealing with in trying to treat me and take care of my health. So thank you for your invitation today.
Thanks, Bud. I got to say, we're so happy. And I know the ACEP family is also so happy that you're doing so well, that, you're back with us doing this kind of work. Good outcomes in PE. I think sometimes in the emergency department, we don't get to see the patient after that initial diagnosis. And so we don't see how people are doing a month later, 6 months later, a year later. And so I think your story is also important when it comes to when we think about recovery. John, it had to have been interesting for you as quality leader, a researcher, somebody who's been in the quality space, to be in a project working with Bill and him having that diagnosis as part of that work.
Yeah, and Bill, thanks again for taking the time. We've worked together now for, it's got to be approaching 4 to 5 years, largely around measure development for venous thromboembolism. But I think this might be the first time we've really had a chance to talk about your experience. So thanks for sharing that. A little background for me or about me. I'm an emergency physician and relatively new at the time to measure development and was leaning heavily on Bill's expertise as we were developing balanced measures of diagnosis for PE within our system, and Bill was, along with ACEP, working together with us to provide some consulting services. And in the middle of that, as we kind of go from a meeting where we're mining the data and wondering if all the symptoms and signs can be found and are we going to be able to extract the diagnostic image reports, we hear that Bill's not going to be able to make a meeting and then he can't make the next meeting. And it came to light that he had the very diagnosis that we were seeking to develop a measure for. And so, Bill, I guess the question I have for you, having gone through it, all your expertise on the data extraction side, data management side, measure development side, then you go through this process, which wasn't a simple in the hospital system for a day and out, but a fairly long diagnostic and treatment journey. And then you come back to the very same topic. Did that change your perspective at all on the approach you took to measure development? Did it let you see measure development in a different light? Did it change kind of the way you conducted subsequent approaches to measure development?
Well, that's a great question. It was an interesting experience because, well, for two reasons. First, I had a lot of free time. So I was in the hospital and there's not much to do. So I spent a lot of my time looking into VTE. I mean, I had it. So I was looking at our measure, I was looking at the things that were going on. I was looking at things that were specific to my health experience and my health overall, and how those things might impact what was going on with this diagnosis and the treatment that I was receiving. So how would those things have factored in to measure development as I had been engaged in that with Yale and with this team? How would things that were occurring to me at the hospital as I was going through this, how might those be a part of the measure calculations? What other ways might we look at analyzing VTE and how it impacts patient outcomes as my experience unfolded there in the hospital? I became quite interested in things like, well, what about my thrombectomy? You know, when that was proposed as what they wanted to do, what's the outcome there? What were the things that might get measured, and how might I measure my own outcome in this situation? What would I classify as success or not? And what would the physician need to make those kinds of evaluations? And then specific to emergency medicine, I did reflect on what happened in my intake process, because I did go through the emergency department. I saw an emergency physician, and they were the ones that made the formal diagnosis and looked at what was going on and how severe it was, and making the decision for admission, whether or not I should be admitted, because the DVT was my only condition at the time. So should I be admitted for that or not? Those are all parts, I know, of the measures that we are endeavoring to build here with the registry. And how might that be affecting my own personal treatment? And it gave me a sense of how important it was that these measures be accurate and that they properly reflect the best of patient outcomes and the best of our clinical knowledge and understanding. How do we build them that way? Because I'm the one who will benefit, or maybe I wouldn't benefit from those being ideal. So those things did go through my mind while I was in the hospital.
Yeah, Bill, that's really interesting. Thanks. I think when we start developing measures, in particular for thromboembolism or PE, we kind of see it from, was the diagnosis made or not made? Was the imaging modality chosen wisely or appropriately? Was the treatment appropriate? We don't get into some of the other things that I think may matter, in fact, more to patients. Communication regarding the diagnosis, regarding the workup of the diagnosis, communication of the prognosis. In your case, you went from a diagnosis of a DVT to now needing a procedure, thrombectomy. Did it give you a sense in some ways that the lofty goals of measuring diagnostic accuracy, utilization, yield were not enough to capture diagnostic excellence, meaning we're missing some of the harder, more intangible things like communication, clarity of treatment plan, making sure that it is consistent with patient wishes? Did your experience change any of that perspective?
It did. It's a great question. So part of my comfort in experiencing this that I would not have had otherwise was the knowledge that I had gained through our measure development efforts with Yale. It gave me, somewhat uniquely as a patient, insight into exactly what was going on. So a lot of what I might otherwise have not known, I did know. And that gave me a lot of, well, not confidence, but it gave me assurance that what I was going through was, I understood it. I knew what it was. I knew what was going on to the extent that a layperson could. And I was glad for that. My relatives and others who I also saw in the hospital didn't have that benefit. And for them, this was quite a bit more frightening than it was for me. So you make a very valid point. It's not just about measuring whether or not the patient, fortunately me, came out okay. It was also that the experience during it, was it comfortable? And I did feel comfortable asking specific questions of my physicians. And I'm glad to report they were all very much able to answer them and willing to answer them, took the time to answer my questions. And that is, you're right, that was an important part of me being able to be calm and assured as I went through that treatment. And that was important to me. It made the experience more tolerable. It's not ideal to ever be in the hospital for 4 days, but certainly that was a good hospital experience for me.
Yeah, and I guess it makes me wonder, one of the things that I find both fulfilling but challenging in the measure development space for over a decade is that there are always so many different stakeholder views when you're developing a new measure. One of the jokes I always say is when you're developing quality measures, thank God I didn't develop the EHR, because those guys get the worst rap. And if it wasn't for the EHR, then everybody would hate the people making the metrics. You live in the middle of this with so many groups where, as leading a registry, you're sort of the intermediary between the metrics, developing these metrics that EM groups get judged by, emergency physicians get judged by, trying to keep them in compliance with CMS programs, but also trying to help support them at the same time. Do you feel like, sort of having walked in the shoes of the patient, that there's things that you would now put in that conversation when you're talking to an EM group or when you're talking to CMS that you would never have thought of before?
Absolutely. I think that the part of measure development that's most difficult, and that I know, did a lot of research to try to look at all of the various ways that patients might present. I think the hardest thing is understanding that each patient is an individual. Quality measures, by their very nature, take a more aggregate view, and in doing so, can lose some of the clarity around other conditions and other situations that the patient may be facing. And how do we build that in? Because physicians need to be treating the patient, not adhering to a quality metric. The quality metric is there to help guide and help us understand how the treatment overall is happening for a patient. But at the same time, we don't want that metric to be the driver for the healthcare that's being provided. In my situation, for example, it turned out that I have a genetic disposition towards clots. And so they didn't know that at the time. I didn't know it at the time. And my situation then was somewhat different, according to the physicians I was working with, than it might not have other been. And when we think about those things in terms of quality measures, so how do we make sure that a measure can handle and properly evaluate the majority of cases that fall under a specific set of events versus any outliers where there are special situations or considerations that have to be taken into account so that physicians can still see their good work through the quality measure and treat the outliers at the same time. And I think that's the perception that I got out of this experience, was how do we create these measures that are not so complicated that people can't understand them and follow them, or have to spend a large amount of time to just read through them, yet still make them effective in evaluation of our treatment and the outcomes for the patient and provider.
Yeah, I can already hear you, Bill. You've moved from the patient with the patient experience quickly into the data scientist that you are. So let me take that leap with you and ask you a pretty basic question. After this experience, having lived through it, essentially provided some of the very data that you hope to extract from the EHR, what do you wish you could change about the EHR to make quality measurement a tool for improvement, not just a static measure of diagnosis?
For me, I think the primary thing is more time physician with the patient. That is one of the biggest things that the EHR can help with. Right now, the EHR ends up being an effort in of itself. And we all know this. We all know the documentation requirements and the complexities of putting in the data for physicians. That's time they could have spent with a patient. For me, like I said, I had the benefit of having the knowledge and experience around this exact situation. But sometimes I picture, what if it would have been my mother that had been in my place and had gone through the things I went through? It would have been very helpful for her to have had more time with the physician. Whatever time that physician could have spent with the patient in lieu of documentation within an EHR would have helped both the patient and the outcome, in my opinion. So where the EHRs can really help us, in my opinion, is that how do we gain the documentation necessary around the clinical conditions, around the treatment? How do we gain that information and store it for use in the future, while at the same time not drawing the physician away from the patient to do that work? And I think that's one of the critical challenges in healthcare and for EHR vendors in general, is being able to capture the information about what's going on with the patient, what the treatments are, what the diagnoses are, what's happening, versus being able to actually spend time and communicate that with the patient.
I actually think this is a space where we might actually finally have a lot of things going in the same direction, which is you've got this historical view of quality metrics requiring people to check boxes in the EHR, put in structured data, forms being created so they're compliant with CEP1 or some other measure that's out there. And that's the kind of stuff that drives all the resentment around quality metrics. Now, with the new billing guidelines and there's these new ambient AI technologies, I can imagine a future world where the ED note no longer looks like a structured piece of information at all. It's all free form, created with sort of, large language model started text that the clinician then just reviews at the end of their shift. And it could be a much more cohesive narrative, but it means that there won't be any more of these sort of checkbox for quality measures. And so do you think that like the quality registries and the measures out there are ready to adapt to that future world? Like, could we actually have a future world out there where I just do the care at the bedside I want to do when I'm in the ED? That collects itself as some sort of narrative form of information in the medical record that we can then use some other AI model to extract the quality of.
Absolutely, I think that's where we want to go. I think we're also headed there. The AI improvements that we've seen over the past 18 months have shown us a significant improvement in the accuracy and ability of these systems to pull out the discrete elements of the data and make those available downstream. Quality measures would benefit greatly from that. That way, we would not be asking physicians to document specific things or do certain things just because we needed to be able to report that via a quality measure. So AI and some of the tools that are coming out right now, large language models, these are the things that are going to enable us to do a much better job of making process of data collection for quality measurement almost transparent to the physician. And that would be the ultimate goal. The physician would not have to even consider these aspects of the documentation requirements of quality. They just have to worry about quality. And the rest would be handled by the people who do it, the data scientists, the data engineers. That's the people who should be working with this narrative and with the treatment that's been logged in the EHR and translating that into quality measures without impacting the care that the physician is trying to give.
Bill, what do you think some of the barriers are to getting to that point? It strikes me that the technology is developing rapidly, as you mentioned. I think you mentioned over the last year and a half, you're already seeing major strides. But from the work we've done together, there still seems to be challenges with data blocking, access to certain elements. I can even imagine you having been a patient, having had a diagnostic imaging test, and then turning as a data scientist to try to find the results of that test to put in a measure. You understand, because we've gone through that challenge, that it's really hard to get. What do you think some of the barriers are, and are we making strides, and are we doing so consistently across sort of the different silos of the people who develop these measures?
It's a great question. The biggest barriers that I perceive as we move this technology forward revolve around data access. As you mentioned, data access is one of the most difficult aspects. Not only do you have to have the right data access to be able to build your large language model, to train it, and to make correct interpretations, but then you need data access also for the ultimate result and of the quality that we're going to use for the measure, and to be able to evaluate the quality metric. So data access will remain one of the biggest challenges. There's both a technical and legal aspect of that. The laws currently are written, they're very stringent around data sharing and being able to share PHI, PII data. We have to be very cognizant of how important that data is and how to keep it safe and to ensure the patient's information is secure. At the same time, being able to use this data and train these AI models to understand how to interpret this information so that as we move forward, those models will be able to accurately calculate the quality measure. This is critical because if we create a system and the quality measure has errors in it, if the AI or other tools do not accurately calculate a quality measure, then we can't trust it. So we need to be able to positively know that once these models are being used, that the data that was used to train them is accurate. We have to know that these measures and their eventual calculation is accurate. We can believe it. This is the right number. The critical part of that will be data access. Large language models, they need very large data sets. They need to know that they are accurate so that we can train them correctly. And that will be the key to having this success. The second key, in my opinion, is consistency across the EHR implementations. There are a number of major vendors, and these vendors all have a little bit different approach to their EHR, their data storage, data access, and capabilities. We need more of that to become homogeneous across the vendors, and that will enable two things. First, it'll enable the technology to be able to calculate the same in various situations, but also it means the physicians don't have to worry and change their documentation practice and the way that they treat the patients from system to system and from hospital to hospital, giving them the ability to simply focus on the patient. I think those two things would be the biggest obstacles that we have to overcome.
I mean, those are big, but I think what the interesting thing is, I hope that as the analytic models move fast, the actual tech platforms that live under these EHRs also start moving faster. And if that happens, then you could see a world where data systems themselves are improving faster and faster, and we could really be in a different place on some of this. Bill, there's one question sort of I didn't get to ask you, and I was thinking about your experience as a patient. And that's that most of the quality measures we develop are very much provider-centric. And by that, I mean, we get a bunch of emergency physicians around a table. We talk about what's important. We look at our guidelines and we say, okay, here's what the guidelines say. Here's some research that says a gap. That should be the quality measure. But we know that we're only measuring little snippets of quality. One process here, another process there, one outcome that we believe it's important in that whole patient's journey. When you look back on your experience, is there something like glaring that we're missing? Is there something that you're like, I wish they measured the quality of this from the patient lens around the quality of care? Or was there anything that you thought that was, never gets defined as quality by the doc sitting around the table, but when you're on the other side of that table, you starting to see it as this is actually really important?
I would say that for me, I tried to figure out what was my quality outcome as a patient. So how would I have measured it? And my idea being, how would I create a quality measure so that if I was to assess, did I have a quality outcome for my experience, how would I measure it? How could somebody as a third party, such as our registry, come in and measure this also and give feedback to the physicians and the health system that says, here's this patient and here was the quality outcome as assessed. I think that we are missing on patient-reported outcomes. I think that's a big area for quality measure development. Did the patient feel like that they had a good outcome? Did they feel like the prognosis has been adequately addressed, that they have a plan, that I'm going to be well in the long run? There was certainly still more healing to be done afterwards. So how do we address that? And then how do we help the physician understand that their part of that care was a contributing factor to that success? How do we make that connection? And how do we avoid connections that are not causal? So those are the areas that I think we can grow in the measure development process to better understand how the patient ended up in the long run. I think that that's an area for our development for the future.
Yeah, I think you brought up a really interesting concept, and that's, we tend to look at quality and judge outcome through the lens of a physician. We think we know what the diagnosis is, and we can usually see whether our measures are accurate or not. We know what we want to see to determine whether a diagnosis was made. We might stretch and see if it was made in a timely fashion. And then kind of in a different silo, we ask patients how their overall experience was. But I get the sense that one of the first things, if we could go back in time as measure developers, we should have done is sort of recognize that there may be a gap between what you and your patient experience of your diagnostic journey concluded regarding quality and what the very clinicians who made the diagnosis for you would think is a high quality diagnosis. They may overlap and share many of the same attributes, but my guess is we'd find some pretty stunning differences. And so I think you're right. We need to start getting a sense and developing measures that tap into not whether the clinicians think the diagnosis was appropriate, timely, and accurate, but what do the patients think of the diagnostic process and journey?
Yeah, no, and I think this is all part, though, of where we're evolving with quality measures and how these quality measures start tying into quality improvement more. Sort of building off where John was there, Bill, we give everybody on quality the last word. We give you a soapbox at the end. And so you have your one chance to hit all those medical directors, quality directors, emergency clinicians out there listening with one thing that you wish they knew. What's your one thing?
My one thing, honestly, is that I wish that every VTE patient got as good of care as I got. I did go to a large hospital where they had expertise in this type of diagnosis. So I was very fortunate to get some very good care at that facility. And I know that through my work here and my discussions with various physician groups, not everybody has the benefit of having that kind of facility and resources to be able to expend on every patient. I would like to see that for every patient. I think the healthcare industry as a whole has to be able to provide all of the physicians with the same type of testing capabilities that were available for me. They were immediate. The moment they had any questions, the physician had any questions about what was going on with me, they could send me for a test, and within minutes or hours, we had results. So I know that many physicians in other locations may not have the same access and ability to do exactly what they would like to do as part of the treatment protocol. So I think that would be my biggest thing to not so much the emergency physicians themselves, but to, as you said, the hospital industry as a whole. We have to find out how we can provide that same level of care in all areas of healthcare, all facilities having access, and the physicians and patients having access to the tools that best suit the treatment that they need to give for the patients.
Yeah, I think simply put, we tend to think of measure development as measuring a process that starts when a patient presents and has access to a hospital. We often judge, if we make a diagnostic accuracy measure for PE, we usually look to see when the patients arrive in the emergency department. We're blinded to all the patients who may not recognize the symptoms of a DVT. It sounds like you recognize that. New to present somewhere, had access to present when you called to get your appointment or your ultrasound, you got it in a timely fashion. For many patients, that process is delayed if it happens at all, and it's not measured by us. And so I think that's really another big challenge. How do we address the pre-healthcare interaction phase of the diagnostic process?
Yeah, we've gotten there for MIs, we've gotten there for strokes by creating massive awareness, regionalizing care, trying to think about access to systems for well over a decade. I hope the work we're doing in EQUAL is on the cusp of that for VTE as well. And so, Bill, I'm hoping that someday, your ask isn't just an ask, but something we've delivered on as a healthcare system, as an emergency care system. Me and John want to thank you for joining us today. This was a wonderful episode. Thank you for letting us, hear what it was like to walk in your shoes. Thank you for sharing your experience with us. I know that many of us who lead this quality improvement work around the country find stories like yours, the real fire that's our motivation to make the quality of emergency care better. So thank you.
Bill, thank you.